With Dr. Corlecha, we have the pleasure today to have with us Professor González de Castro, and it's also a privilege for us to have him with us, and I would like to welcome and introduce him. Professor González de Castro has received his PhD from Salamanca, Spain, on molecular diagnostics of hematological tumors. In 2004, he obtained a position as a clinical scientist to lead the molecular diagnostics laboratory at the Royal Marsden Hospital and the Institute of Cancer Research in London. For the last 12 years, he has been the head of the molecular diagnostics department at the Royal Marsden and the Institute of Cancer Research in London, where he has been leading the implementation of genomic, medicine-driven clinical trials in multiple cancer types, including leukemias, soft tissue sarcomas, gastric, colon, lung, skin, prostate, breast, carcinomas, and other tumors. Since 2011, he is one of the principal investigators on the Cancer Research UK Stratified Medicine Programme in close collaboration with the pharmaceutical and biotechnology industry with regards to genomic analysis in personalized medicine for cancer. In 2016, he was appointed Professor of Genomic Medicine at Queen's University in Belfast and is the leader of the Genomics and Bioinformatics teams in the Precision Medicine Centre. He also works as a consultant clinical scientist in the Centre for Cancer Research and Cell Biology and the Northern Ireland Molecular Pathology Laboratory, and is the lead scientist for molecular diagnostics in microbiology at the Belfast Health and Social Care Trust. His research is centered around molecular biomarker analysis. He focuses on developing tools for genomic stratification in precision medicine, immunotherapeutics, and circulating biomarkers to better classify and monitor disease. He is involved in several translational research projects identifying diagnostic, predictive, and prognostic molecular biomarkers in hematological and solid tumors. He has authored more than 150 research papers with more than 10,000 citations and an H index of 47. I should not expand any more on his CV and rather give the floor to him. Today we'll have the pleasure to hear a lecture on applications of cancer genomics and clinical practice. Professor González de Castro, thank you very much for being with us today. The floor is yours.
Thank you very much for such a nice introduction. It's my pleasure to be here today and give a lecture, which I'm going to try and share my screen. Hopefully this will work. I hope you can see my screen and the presentation. So I'm going to give today a lecture on applications of cancer genomics in clinical practice. So these are my disclosures, first of all. And there are several clinical applications for genomic profiling in tumors. I like to think that there's mostly 4 applications. One is predictive biomarkers. So these are the ones that basically relate to the specific therapeutic response to certain drugs. So these are what we normally use and what's made more popular genomic profiling and companion diagnostics such as EGFR in lung cancer or BRAF in melanoma, KRAS and NRAS in colorectal, BRCA1 and 2 in ovarian and prostate, etc., etc. So some of these are also tumor agnostics, such as microsatellite instability or tumor mutation burden, NTRK alterations, etc. And these are the ones that decide whether a patient is eligible for particular therapies. But there are also applications outside of drug therapies, such as diagnostic markers. There are very good and very robust markers for diagnosis, particularly in certain diseases where the classification relies heavily on the characterization of the molecular markers, such as lymphomas and sarcomas, and we'll see a few examples later. You can also use them for prognostic stratification of different tumor types, like those that can specify if a tumor is slightly more aggressive or more benign, whether the general outcome of those patients are going to be better or worse, and decide clinical management accordingly. And then finally, they're very useful to monitor residual disease. And this has been used for many years in leukemias and is now being implemented in solid tumors thanks to the applicability of liquid biopsy, which we will see also in a second. So I'm going to talk first about the first point of predictive markers. And I'm going to use a real-world example that we have for non-small cell lung cancer, which I think we're all very familiar with because the applications of genomics have completely transformed this disease. And I think it's worth rewinding back to 2008 when this was the most exciting thing that happened in non-small cell lung cancer. And it was the distinguishing histologically between adenocarcinoma and squamous cell carcinoma, because there was a slightly but significant improvement of just a few weeks with doublet chemotherapy. And this was very exciting at the time, but obviously it was not very important for patients. So just you have to just understand that the classification of non-small cell lung cancer based on the molecular characteristics makes it the poster child for precision medicine. So this slide here, which is quite old now, is about 6 years old, it sort of identified different molecular subgroups of lung cancer, not just the EGFR mutations, which are probably the most common one, but also the KRAS mutations, ALK alterations, MET amplification, HER2, ROS1, BRAF, RET, etc., including NTRK as well. And this obviously made lung cancer a very, very good target for drug development and precision medicine. As of today, I think the very minimum standard of care for first-line treatment of non-small cell lung cancer is the detection of EGFR, ALK, EGFR mutations, ALK fusions, and also, of course, PD-L1 immunohistochemistry. And I would say this is the very minimum that a patient with non-small cell lung cancer, particularly adenocarcinomas in particular, will need in order to start treatment. But this is not just the only markers that are currently approved. In many European centers and of course in the US, you would be looking at ROS1 rearrangements to consider use of crizotinib, given the fantastic responses that these patients can have. You would also be looking at BRAF mutations because the combination of BRAF inhibitors with MEK inhibitors has demonstrated a significant benefit for patients with these alterations in non-small cell lung cancer. You would now more recently be considering the detection of RET fusions in lung cancer. There's also the approval for RET mutations in thyroid cancer. And as you can see here in the waterfall plots, response rates are over 70% in patients with non-small cell lung cancer and RET fusions. And this translates in a progression-free survival that is quite significant, particularly in patients that have not received previous therapies. So we will also consider the detection of MET exon 14 skipping mutations. Exon 14 skipping mutations are those that result, as you can see in the cartoon there. So mutations that basically mean that there is alternative splicing between exon 13 and exon 15 of MET. And this makes a MET protein that is constitutively activated and can be targeted by specific MET inhibitors such as tepotinib or capmatinib. And these are the results that we have seen very recently in the last couple of years, which again, very good responses. And there's a very small proportion, but a significant proportion of patients with these alterations. So as you can see, there are many alterations in non-small cell lung cancer today, just about 10, 12 years after the initial approval of EGFR mutations for tyrosine kinase inhibitors. And this has given these patients a huge opportunity to be able to be treated with targeted therapies, and therefore we need to detect all these alterations. In addition, in the last few years, we've also seen even more advances on the development of second and third generation of these drugs. So this is the example of the next generation of ALK inhibitors, which was the phase 3 study was published in New England 2 years ago for lorlatinib. And as you can see here, the increase in progression-free survival, which is translated in overall survival benefit compared with crizotinib, is absolutely tremendous. And these patients now, particularly those with CNS disease, they have a significant possibility of long-term survival, which is fantastic given the heart disease that these patients have. Similarly, third-generation tyrosine kinase inhibitors for EGFR mutation have pretty much double the progression-free survival, and it also results in a significant improvement in overall survival. And this is not just in the metastatic setting, but we're now starting to see the translation in early stage, and particularly with third-generation tyrosine kinase inhibitors, we saw a couple of years ago a significant and very, very substantial improvement in progression-free survival for patients with stage 1 to 3 resectable lung cancer as adjuvant therapy. So we're seeing all these changes happening. It means that we need to have all these genomic biomarkers available for our patients. And lung is being used here as an example because I think it really is the poster child for precision medicine. But we've also seen significant advancements with BRAF mutations in melanoma, or RAS mutations in colorectal, BRCA1 and 2 in ovarian and prostate cancer, KIT mutations in GIST, etc., etc., etc. Now, what are the strategies that we can use in our sort of national health systems for laboratory testing in routine clinical practice? So how can we bring this testing in our routine practice in our pathology labs? Well, first of all, it's I think we need to bring genomic technologies because the availability of material is not always as much as we would like to think. Again, going back to lung cancer, where very frequently we have a very small specimens, either cytology or small fine needle biopsies or aspirates, you need to do a significant amount of work, not just for the diagnosis with immunohistochemistry, but also, as I've just mentioned, for multiple molecular biomarkers as well as immunohistochemistry, such as PD-L1. So how can we do all these markers without exhausting all the very little material? This is where genomic analysis and genomic panels come into the equation. So a few years ago, we started in the UK the Stratify Medicine program, and we translated that into a national trial called the Lung National Matrix Trial, where basically we were using a bespoke next-generation sequencing assay designed specifically for non-small cell lung cancer. And this assay was basically the selection for eligibility to one of the 21 arms that were being developed with different therapies or combination of therapies. What we saw in the publication recently of this trial is that only 4 of the arms were actually achieve a positive result, some of them including drugs that have already been approved, and new ones that are potentially very promising and might result in further trials. But what this shows, irrespective of the outcome of the different arms, is that with a single assay, you can potentially look at eligibility for many, many different potential therapeutic options. And I think this started setting up the pace of how do we implement genomics in the clinic. So what technology do we need to choose? There are many different technologies, and I think it can go to as little as our common sort of qPCR. We used to use COVAS for EGFR and KRAS mutations, but that only detects 1 or 2 genes, very good sensitivity, but very limited. On the other extreme, we will have things like whole genome sequencing or whole exome sequencing, where you can get information across the entire genome, which is very comprehensive, but the sensitivity is insufficient for routine clinical practice and particularly challenging with formalin-fixed material. So we can just sort of use next-generation sequencing, which is somewhere in the middle. It basically can analyze about 100 of genes at the same time, and the sensitivity can be improved by using some degree of optimization with these approaches. Most laboratories these days will use capture hybridization next-generation sequencing. This is the approach that is used for the large panels such as the Foundation Medicine or the Impact from Memorial Sloan Kettering in New York, and also for whole exome sequencing. Basically, in this particular approach, what you need to do is you have your DNA extracted from your specimen, and what you do is you prepare a library of molecules, which is the DNA of that individual patient is prepared in a way that is suitable for further enrichment. You hybridize that DNA with a set of probes that include DNA for all your targets of interest, the 20 genes or 100 genes or 500 genes, or if you were doing whole exome sequencing, it would be 28,000 human genes. And once you capture those genes that you're interested in, then you proceed to sequence and analyze the data. And this whole process these days tends to take about 2 to 3 days in the majority of cases. So it's not significantly challenging in relation to the turnaround time. Now, we need to choose a particular panel, next generation sequencing panel, and there are two main options here. One is to go for a comprehensive genomic profiling. This would be using a large panel that includes pretty much all the cancer genes that you might be interested in every single tumor type. And the advantage is that you just have one single solution for all of your samples, independent of what clinical indication, what tumor type they are. So it's very useful for the lab to just be able to use the same approach for all the samples, irrespective of whether they are colon, lung, melanoma, or any other type of cancer. It also has one analysis, and basically it means that it simplifies what the labs do. However, it also means that it's very large and therefore expensive. And inevitably, there's always going to be compromises for very specialized targets, because you don't want to waste an awful lot of footprint in your panel for something that is only present in 1% or 0.5% of your cases. So the other option is to use bespoke profiling, which this is a situation where you have different tests, different assays for different clinical indications. The advantage, obviously, they're smaller and therefore cheaper. You can achieve higher depth. You do not compromise. You can actually include every single target that is important and relevant for that particular disease. And it also means that as and when there's a new biomarker that is approved or a new type of target that might be needed, you just need to deal with that particular indication rather than your entire workflow. The disadvantage, of course, is that you need to keep stock of several panels, like you do, for example, for fish. You have to have multiple probes. And also it would include bespoke bioinformatics for each individual assay. So I'm going to give you some examples that we have used in our lab for specialized diagnostic indications, where we have designed specific bespoke analysis. One is sarcoma. So as you know, soft tissue sarcomas are a very rare type of tumor, and there are many different histological subtypes. Thankfully, a lot of these histological subtypes, about a third of them, are characterized by a pathognomonic genetic alteration, generally a gene fusion. And there's been to date over 150 different sarcoma fusion genes that are significantly related with the diagnosis, and therefore they have been incorporated in the WHO classification. However, there's so many of them that is quite challenging, and having multiple fish probes or different assays could be very, very challenging. So we decided to design a specific and next generation sequencing capture approach, which will include all different fusions that have been described today, as well as amplification of certain genes, particularly MDM2 and CDK4, of course, for liposarcomas. And basically, we had an assay that would include about 650 different regions of the genome, and will basically cover about 550 kilobases. We proceeded to validate this approach in a large cohort of soft tissue sarcomas. You can see here 100 cases in which 97 of them were detected exactly the same fusion that was detected by FIS or RT-PCR. So very, very high sensitivity. This includes also the detection of MDM2 and CDK4 amplification in well-differentiated or differentiated liposarcomas, as well as an intimal sarcoma. So very good, very useful approach, high sensitivity and specificity in formalin-fixed paraffin-embedded tissue. This was all done in clinical specimens after histological diagnosis. Another example is lymphomas, and as you know, not just lymphomas, but also leukemias. The newest WHO classification in 2016 has expanded on the use of molecular targets for the classification, not only diagnostic classification, but also prognostic and risk stratification of many lymphoproliferative disorders. I'm not going to go through all of them, but for those of you that are involved in hematopathology, this will be familiar to you. And one of the current issues in the diagnosis of lymphoproliferative disorders is that the molecular workup involves multiple technologies. So chances are that you will need to do some FISH for some of the fusion genes, like MYC translocations, BCL2, BCL1, BCL6, etc. You might also have to do some sequencing analysis for mutations in P53, Notch1, EZH2, etc., etc. You might also need to do some copy number by FISH or MLPA. Frequently, you might require to do clonality of immunoglobulin or T cell rearrangements, which can include between 5 and 18 different tubes. And all of this causes significant delays in the turnaround time of the integrated report and challenges because not one single individual can see all the information in one go. So within the Euroclonality Foundation, we designed an NGS DNA capture panel, which basically capture all the variable diversity and joining genes of the immunoglobulin heavy and light chains, as well as T cell receptors alpha, beta, gamma, and delta. This means that we can detect not only clonality, but also any translocation that is juxtaposed to one of the immunoglobulin or T cell receptor genes, which is very useful because we don't need to know the partner. It will be sequenced by means of being next to something that has been captured. In addition, we added a range of mutations that are relevant for the classification or prognostication of lymphomas and leukemias, as well as copy number alterations and some switch regions for translocations in post-germinal center, germinal center lymphomas and multiple myelomas. So again, a relatively small panel of 350 kilobases. And we validated this with samples from 10 different European labs, and these were sequenced across 7 European labs. So first, we analyzed a proficiency cohort of cell lines to ensure that all the labs have enough experience to be able to do this analysis, and it was all successful from the first pass. And then we proceeded to analyze 280 samples, 88 of which were formalin-fixed paraffin-embedded material from lymphomas. And we analyzed the performance, the analytical performance, as well as the concordance with the gold standard technologies in the clinical labs. And these are the results. For clonality detection, there was a 97% sensitivity for the detection of B and T cell clonality down to 5%, with improved detection compared to Biomet2, particularly for Ig-kappa. The translocation detection was 95% sensitive and more than 98% specific. And it would allow us also to detect novel translocation partners that wouldn't be able to identify by current methods such as FISH. The detection of mutations, as expected, was very high concordance, more than 99% concordance with orthogonal validation, to a level of 4% of allele frequency. And finally, copy number alteration was also highly sensitive and specific, and particular in the detection of alterations in diseases such as CLL or multiple myeloma, where they're critical for the diagnosis. So these are just a few examples of where bespoke panels specifically designed for indications are very useful in the clinical setting. So far, I've been mostly focusing on the analysis of tissue material or genomic DNA from tumor cells. But I just want to finish this lecture with the last section focusing on liquid biopsy, which, as you are all familiar with the analysis of plasma DNA, it provides an increased access to genomic material in solid tumors, which can be useful in many different circumstances. So for those of you that are not very familiar, cell-free DNA is DNA material that is released from healthy normal tissues. All of us, if we were taking a blood sample and we purify the plasma, we will be able to detect approximately between 5 and 7 nanograms of cell-free DNA per milliliter of plasma in each of us. And this is material, DNA material, that comes from the cells that are undergoing apoptosis in our organism, whether it's because of renewal or many different processes. And these sorts of cellular debris need to go to the liver, need to go to the kidneys to be released. And in the process, it can be detected by taking a blood sample. Now, if you have a patient with cancer, a proportion of this cell-free DNA in plasma will be derived from the tumor tissue. And this is called circulating tumor DNA. Now, there's applications of circulating tumor DNA in cancer, which are multiple. We'll go through some of them in a second. And as you can see here, parts of the applications could be early detection and monitoring, and also applications in the detection of resistant mutations after therapy. So many different applications have been described, and the increase in circulating tumor DNA is associated with increased tumor burden as well as the stage of the disease. The processing of these samples is very easy. It can be done in any basic clinical lab. You just take a blood sample, you centrifuge for a few minutes, and you will have your 3 layers. You just take the plasma out and extract the DNA from that sample and proceed to analyze the cell-free DNA. So I'm going to give very briefly some examples of the different applications in the clinic for ctDNA. We can use to detect predictive biomarkers as a surrogate for tissue when there is not enough tissue or the tissue has been exhausted. We can also use it to detect mechanisms of resistance. And in these cases, when the diagnosis was already being made before first line, this can be very relevant to consider what therapies can be used for second line rather than taking another biopsy. We can also use for risk classification and prognosis for minimal residual disease detection, as well as a diagnostic tool to help the tissue diagnosis. So first of all, the detection of predictive biomarkers. The best example was given a few years ago by the detection of the gatekeeper resistant mutation in EGFR, the T790M, which is responsible for about 50% of patients with EGFR mutations and treated with tyrosine kinase inhibitors in the first line. And as you know, the third generation TKIs had a significant response. And as you can see here from these waterfall plots, whether the mutation was detected in the tumor or whether it was detected in the plasma, the overall response rate is the same, about 62% or 63% in plasma. So these results were very, very interesting and very, very good for our own workflows, because then we could consider in the resistance setting to take a blood sample instead of a rebiopsy. If you take a blood sample for ctDNA analysis and you do find the T790M mutation, the patient can be treated with an inhibitor without need for further tissue testing. In the cases where the T790M mutation was not detected in plasma, you would then consider to request a tissue biopsy, because a significant proportion of patients could still be positive in tissue. But this was the first time that ctDNA became standard of care in clinical practice in non-small cell lung cancer, again, as an example. There are many other uses for cell-free DNA analysis, and particularly the risk stratification and prognostication, I believe, is the area where we're going to see a great benefit for patients and a potential complete change of how we stratify our patients. Here are some examples that have been published over the last 7 years. The first one is in early breast cancer, which I will explain in a bit more detail in a minute. The second one you can see here, this is a publication from 2006 in stage 2 colon cancer. And as you can see, the blue line here are in panel A are the patients that are ctDNA negative after surgery. And as you can see, very few of them would have progressed and developed a recurrence, whilst all the patients that were positive after surgery, they developed metastatic disease within 2 years from surgery. And not only is this very significant, and as you can see, the hazard ratio here of 18 is very dramatic, but I think it's also very important that it has a significant prediction of risk, even in the different clinical risks. So if you see panel C, you can see the patients that have been classified as clinical role risk. And again, the majority of them would have been ctDNA negative after surgery, and they would do very well. And only those that were positive seem to progress. And similarly, for patients that are high risk, the detection of ctDNA is significantly associated with the risk of recurrence. So as you can see, this further refines the way we can stratify our patients. And I think this would bring a fantastic tool for the oncology team to decide which patients might benefit the most from adjuvant therapy and which patients would benefit potentially more from other approaches such as watch and wait screening, or perhaps consideration for immune surveillance. We can also see the benefit in leukemia in lymphomas, such as diffuse large B-cell lymphoma. So again, this is a publication from a few years back that was very, very significant. And as you can see, patients that finished treatment and were ctDNA negative, they had about 80% chances of cure, compared with only 40% with patients that were still positive after 3 or 6 cycles of R-CHOP in this case. And this was translated in overall survival as well. So as you can see, a very significant improvement in the stratification of patients based on the detection of ctDNA. I'm going to go in a bit more detail in the example of breast cancer, because I think it was a very good way of seeing how this can enhance the current stratification of these patients. So this was a study that was carried out by a group of Nick Turner in the Institute of Cancer Research in London. And they took patients with breast cancer where they had a blood sample at diagnosis. They also took a biopsy. The diagnostic biopsy was sequenced. And with this sequencing, they identified particular markers that were very specific for the tumor. And then after surgery, they collected multiple blood samples, one straight after surgery, and then every 6 months thereafter. And they look for this very specific marker that was already detected in the diagnostic biopsy to see when and if that mutation would appear in the blood of patients, and therefore meaning that the cancer has returned or was never fully removed. And these are 2 examples of 2 different patients, patient 1 and patient 6. They both have exactly the same mutation, as you can see, the PIK3CA 3140A to T. And pretty much they have the same level of copies of circulating tumor DNA per milliliter of plasma. One had 12, patient 1, and the patient 6 had 16 copies of plasma at baseline. After surgery, as you can see, the first patient had 0 copies of the mutation detected, whilst the second patient had 7 copies per milliliter of plasma. That already tells you that the first patient looks like the tumor is probably all gone and has been resected, whilst in the second patient, the fact that after surgery you still have detection of mutant DNA in plasma suggests that the surgery was not enough. There was probably micrometastatic disease somewhere else that would eventually come back. And indeed, in this patient, 6 months after surgery, there was a detection of a significant higher number of copies. And soon after, the CT scan demonstrated a clinical relapse. Whilst the other patient that which there was no ctDNA detected after surgery, it remained the same after 2 years. When you look at the survival curves, you can see that patients just at a single time point after surgery, the lack of detection of ctDNA is associated with more than 60% survival rate after 3 years, whilst if you do have ctDNA after surgery detectable, within 6 to 12 months, all patients would have developed metastatic disease. If you actually enhance this, and not just one sample after surgery, but then subsequent follow-up every 6 months, you can see how the patients that remain ctDNA free are free of disease in a large period, at least 3 years, whilst those that have ctDNA detected at any point during follow-up, they would inevitably relapse and develop metastatic disease. So you can see how this is incredibly important, and it gives us a brand new tool that we didn't have. This detection of molecular relapse is actually coming sometimes 6 to 12 months before the imaging detectable clinical relapse, which means that we can start considering treatment much earlier for these patients and potentially recruiting to different clinical trials. Again, going back to lung cancer, there's always a lot of data in lung cancer, and this was a study by Tony Mock where they were looking at patients with EGFR mutations that were treated with either placebo or TKI, erlotinib. And what they were looking at is detection of EGFR mutations in the plasma, in the ctDNA of patients. And as you can see, both arms here at baseline had the same level of ctDNA for the EGFR mutation, whilst after 3 cycles of treatment, The patients that in the group of placebo, most of them have detectable disease, whilst the patient that received erlotinib, the TKI, most of them had no detectable ctDNA apart from these 9 patients here. After progressive disease, you can see again the levels of ctDNA were pretty much similar across all patients. So the interesting thing is, what happens? Is there a difference between patients that are ctDNA positive after 3 cycles of therapy versus those that become negative and pretty much you cannot detect tumor DNA in the plasma? And indeed, there is a very significant difference. And as you can see here, the patients that remain EGFR mutant in plasma after 3 cycles, they have a median progression-free survival of just 8 months compared to 16 months for those that are mutation negative. And again, this translates in overall survival benefit of 32 months for those that are negative versus 17 or 18 months in those that were mutant. So again, by just taking a single blood sample after halfway through the treatment of these patients, 3 weeks after starting treatment with tyrosine kinase inhibitors, you can detect which patients are likely to progress relatively soon versus those that are going to have a longer benefit. And therefore, you can potentially stratify and organize clinical management accordingly, particularly given the age of these patients in the majority of cases. And then in more sort of general terms, the possibility of monitoring MRD over time, it again offers fantastic possibilities, not just in lung cancer, but also in ovarian cancer, breast cancer, colorectal, melanoma, etc., where you can track the mutations that were detected at baseline after therapy. They generally would go through a drop in copies in plasma because the therapy is working. And as soon as the patient starts with the initial molecular relapse, you will start to see an increase in copies of mutant DNA in plasma until eventually it reaches the point where the clinical progression is evident. So again, it gives you a few months notice that the patient is going to progress, and therefore you can potentially start organizing second-line therapies. Remember that non-small cell lung cancer patients now can have on average 3 or 4 lines of therapy due to the different combinations of targeted therapies, chemotherapies, and immunotherapies. So very important that we start taking into account these different combinations of monitoring disease using circulating DNA. And then the final application, as I mentioned, is also to help with the diagnosis. And again, going back to our study that we performed, that I presented to you earlier on sarcomas using an NGS panel, the benefit of using an NGS panel that is based on DNA is that we could use the very same approach in patients with sarcoma where we had plasma DNA and look for circulating tumor DNA. So we had a very small cohort of patients given the rarity of the disease and the availability of plasma, but we were able to detect in about 50 to 60% of patients the fusion gene in the plasma. And these fusion genes, again, they're pathognomonic, so they're generally, most of the times, very directly linked to the diagnosis of the patient. So this is a potential way of improving the diagnosis of soft tissue sarcomas by having a plasma sample alongside the tissue sample for histology and being able to detect these fusion genes or amplification of MDM2. So again, similarly to sarcomas, you could also consider applications in leukemias, in lymphomas particularly, where you can detect these alterations without moving the tissue sample, which basically brings possibilities for those cases where the tissue is insufficient or heavily degraded, or if you want to do a biopsy in a particularly tricky area. So with this, I would like to present the conclusions, which basically, in my opinion, I think that significant improvement in the cancer outcomes over the last decade has been possible thanks to the use of genomics, both in solid and hematological tumors. Genomic analysis now in tumor tissue can identify patients that benefit from targeted therapies, and liquid biopsy is part of the standard of care. and is likely to become more prevalent with treatment and monitoring of solid tumors in the next coming years. And then finally, hopefully the data is very convincing that next generation sequencing panels are suitable clinical tools that can be incorporated to support the integrated diagnosis of hematological and solid tumors without significant compromise in sensitivity and specificity. So with this, I would like to thank you all for your attention, and I will be very happy to take any questions that you might have. Thank you.
Thank you very much, Professor De Castro, for the literally excellent talk. You present a comprehensive and informative overview on cancer genomics and precision medicine, which is incorporated as a clinical standard care. I'm wondering, in what terms do you believe that pathologists have a crucial role in a pre-analytical level?
It's very, very important that the pathology lab ensures that the processing of the tissue is not just optimal for histological and immunohistochemistry analysis, but also for molecular analysis. As you all know, some of the processing steps can be very harsh on the DNA, and in some cases, particularly now that everybody's using automated processors, some of them can be really, really efficient, and they can process an enormous amount of tissue in very short periods of time. But that might sacrifice the integrity of the DNA. And I think, given that the vast majority of cancers are going to start requiring comprehensive genomic profiling, I think it's very, very important that the pathologist ensures that the lab processes the samples, not just for histology and immunohistochemistry, but also for DNA as a critical part. And it's also very, very important that the pathologist assesses the different blocks, because in cases where you would have multiple blocks, the most representative one, the one that, for example, has the least degree of inflammation or necrosis or potential, or there are other issues that can cause artifacts in the DNA sequencing, it is very, very important that at the time of diagnosis, the pathologist assigns the best possible block for molecular analysis, because then any further analysis that requires molecular, whether it's now or in the future for clinical trials, can be immediately retrieved from the archive without having to revisit the case. This is going to be very, very prevalent now for prostate cancer, because you would have sometimes 20 or 25 different cores, and making sure that you've selected a few for molecular analysis will save an enormous amount of time and hassle in the future. So it's absolutely key that the pathologist plays a central role from the very beginning.
Yes, and maybe it's a crucial role sites and in the assigning the accurate percentage of tumor cell content. And I'm wondering if there is any standardization of this particular procedure.
Yes, again, the estimation of tumor content is very important, because some of the genomic tests that are available, they have a limit of detection that is dictated by the tumor content. So you would be familiar with some clinical trials that have been published where the failure rate is being, again, prostate is one of the better examples. One of the phase 3 studies that was published, and the analysis was done in Foundation Medicine, up to 35-40% of specimens failed, and about half of those were due to low tumor content. So it really relies on the pathologist to really estimate the tumor content appropriately and make sure that the best block with sufficient tumor content goes for molecular analysis. Otherwise, the failure rate would be very, very high. So absolutely, it's very important also for the detection of copy number alterations, where most cases will require a very minimum tumor content before the copy number algorithm can work. So it's very, very important that the pathologists estimate the tumor content as accurately as human possible.
Is there any other question?
Can I ask a question?
There's a question in the chat, and until such a question comes, may I ask a question to Dr. Gonzalez de Castro?
Yes, please. Yes, Professor.
Following on Dr. Coletta's question, you presented a talk a couple of years ago on a Greek seminar from the oncologists. And exactly on that subject, you had introduced something that, to me, it was the first time that I was hearing that, not only looking on the 2D, how much is on 2D the tumor cells versus the lymphocytes, the small cells that take up much less space compared to a large tumor cell, but also the 3D of the tissue. So could you briefly give a hint to our to the people who hear this talk of how would they manipulate their calculation mentally to account for the thickness of the tissue?
Yeah, no, absolutely. That's a very good question. Thank you. So yeah, as you quite rightly say, that for example, when you have some of the samples where there is significant inflammation, and you have pockets of inflammation, those lymphocytes would be like 5 or 6 microns, right? Whilst the adenocarcinoma cells could be 30, 40 microns, particularly in some tumor types. So when you think about what you're seeing down the microscope, and if you were able to estimate, kind of not counting, but giving an estimation of the number of cells of different types, you could see something being, for example, 50-50 on the microscope. But when you then send that specimen for molecular analysis, you're going to cut multiple sections of different thickness for DNA extraction. So let's say if you cut 5 sections of 10 microns, that's 50 microns in total. Every single lymphocyte that you have in that pocket of inflammation, when you cut a 5 micron, the entire DNA will be going into the DNA. For an adenocarcinoma that is 40 microns, only 20% of the DNA will go into the DNA. On the next section, again, you have the full set of lymphocytes, but only 20% of the adenocarcinoma. So as you go deeper into the tissue, the amount of DNA coming from the lymphocytes is going to start being more and more compared to the DNA that comes from the adenocarcinoma. So what you might have seen in 2D as being 50-50 could very easily become 80-20 or even 90-10. And then suddenly you have a problem with the amount, there'll be more wild-type DNA from the lymphocytes than tumor DNA from your adenocarcinoma. So first of all, try to avoid areas of inflammation as much as possible, but sometimes that's not possible, particularly in certain immunogenic tumor types, like colorectal particularly, and some of the lymph nodes that you might have. And secondly, if you cannot avoid the inflammation or any other microenvironment cells, just try to account for what percentage you think is going to make a difference when you cut through the tumor. And that will depend not just on the size of the cells, but also on the density. Generally, inflammation is the main problem because it could be very dense. Whilst if you have muscle or epithelial, they tend to be very separate. So it shouldn't affect too much. But a good pocket of inflammation, which I think everybody sees very frequently, can very, very severely transform what you think is a 70% tumor content into 10%. And then it becomes very difficult to have accurate results. So yes, it's a bit of getting used to thinking in a slightly different way, but it's, you obviously look at it every day. So it's relatively easy to get used to.
Other question, since we have a little bit more time. This data that you presented on circulating DNA is very interesting in terms of prognostication and risk stratification, etc. So how soon do you think this will come in prime time and adding versus the benefit, to the cost? And come in such a cost that will be worthwhile doing without blowing up all the healthcare systems?
Yeah, so that's a good question because it's very interesting how different tumor types have different means of becoming routine clinical practice. In hematology, as you know, almost everything becomes clinical practice without anybody really thinking about how much it's going to cost. Whilst for solid tumors, it tends to be more of a problem. I think the main aspect is going to be the clinical trials. So I know there are clinical trials currently ongoing. So all the data that I've shown you is generally retrospective studies. On the back of those studies, prospective studies were set up, and they've been recruiting for the last 3 or 4 years. And as soon as those clinical trials start being published with prospective randomized studies, and the results look the same, and you can very clearly and very significantly distinguish which patients are at high risk of progression versus those that are not, I believe that will become standard of care, particularly if it's associated with a change in management, such as the adjuvant therapy, yes or no, or different types of adjuvant therapy, or increasing in sort of the frequency of screening. So I believe we'll start to see the outputs of some of those clinical trials in the next 2 years. And on the back of that, presumably there would be incorporation into clinical guidelines. And I think it'll become more difficult not to do those things for us, because if ESMO, let's say, publishes guidelines suggesting you need to do this in stage 2 colon cancer or in breast cancer, I think it will become very difficult to not provide that to our clinical teams. Where we're going to find the money, that I don't have the answer for that.
Do you think the cost of these exams will go down? Is it foreseeable that it will go down?
They're actually nowhere. So we started doing ctDNA probably about 8 years ago or so. And it was very difficult to do it well with next generation sequencing. And it was very expensive. Today, you can if you use a commercial provider, of course, it's more expensive. But, in laboratory practice, you can relatively easily set up a test that would cost you around maybe 200, 250 euros. So I think if you have a test that for 250 euros can tell you a patient that is unlike pretty much, 80, 90% chances of being cured with just surgery versus those
chemotherapy or something, yes.
Compared to the chemotherapy and it's nothing. So I think it would be, if the results of the clinical trials are good, I think it would be adopted.
Okay.
Can I ask a question?
Yes, I would like to have your comment and your experience on how can we improve the TCC content evaluation. Since several studies have shown that TCC is empirically overestimated, but some training programs or feedback can be improved. May I have your comment on this?
For the tumor content?
Yes. How can be improved the estimation of pathologies?
Right. So we developed a training program with here in the UK with I think is with Higher Education England. So if you go to Google, and I think it's called something alongside of tumor assessment in the genomic era or something like that. If you Google that, you should end up in a UK site, which is Higher Education England, which is obviously the national healthcare system. And there is a training module there, a couple of modules that we developed with them, and they're free. So if you're a healthcare professional, a pathologist or a biomedical scientist, it's free, and you can go through the modules. And at the end of the modules, there is an assessment of, I think there's about 60 different H&Es with different tumor types. And then you can test your what you've learned in the modules and do your assessment online with digital images. And then you get a certificate. So if you get over 80% of them correctly, you can get a certificate. It's nothing formal. It's a very informal thing, but it's something that will help potentially everybody to at least talk the same language. It might not be the absolute truth, but at least it's something that we can all talk to each other, rather than right now everybody has a slightly different approach. And some people focus on the area, some people focus on the number of cells. So at least it helps us to speak the same language. So I'll recommend that to try that one, which is a free tool online, and yeah, start there.
Yes, I think that even TCC, the term TCC, tumor cell coded, gives the wrong impression because it's a percentage of tumor cells in the total area. Gives that impression erroneously. But what we need to know is to estimate is the percentage of nuclei, neoplastic nuclei, and the total nuclei of an area, including the non-neoplastic ones.
Exactly. So the denominator should be everything with DNA on it. So you exclude red cells, but apart from that, and areas of necrosis you probably would have to exclude as well. But apart from that, everything goes into the denominator, and the numerator is just the neoplastic cells, as you quite rightly say.
And since you have an experience in image analysis on that, do you think digital pathology would be of help? Or even by integrating the image analysis data with that of genomics?
I hope so. There's a huge interest. We have a few projects here. We're working with some companies that have tools to estimate the tumor content with H&E by digital pathology. And I hope that eventually they are validated for clinical use, because that would make our lives much easier and we can focus our time on other things. Yeah, hopefully.
I think we have a question from the hall.
Yes, there is one question. Now that you heard us, thank you. Thank you for a very enlightening presentation, Dr. Castro. My name is Eleftherios Eleftheriadis, and I wonder if you could give us a very brief insight on how is clinical molecular testing organized in the UK. What percentage of specimens is referred centrally, and what is tested in-house, let's say?
It's difficult to give a brief one, but basically the current situation in the UK, in England, they have chosen 7 genomic hubs across the whole of England, geographically distributed. In Scotland, there are 4, 1 in Northern Ireland and 1 in Wales. All the samples are tested by these labs in the national health systems. Any samples go to private testing, apart from perhaps specialized things like homologous recombination deficiency. And the percentage of samples tested is now, I would say, out of all the tumors, all the advanced tumors, right? I would say it would be probably close to 60 or 70% of samples, because now that we have included prostate, thyroid, breast, etc., there are very few tumors left that don't require genomic analysis. And I believe that will probably become necessary very soon because of NTRK fusions, for example, which is pan cancer or MSI. So yeah, approximately I would say 60 to 70% of all advanced cancers are tested for molecular analysis in the UK.
But you have certain limits of detection required for the specimen or a specific tumor DNA content to be appropriate to be tested centrally, right? What happens to the rest of the specimens?
Yes, you're absolutely right. So approximately, depends on the testing approach and the different laboratories, but approximately between 10 to 15% of specimens might fail. Mostly probably would be lung cancer and prostate cancer, because they're very small biopsies sometimes, and in prostate very old. Whilst, for example, in colon cancer or melanoma, I would say the success rate is probably closer to 95, 97%. So it depends on clinical indication as well. But those that fail, this is where circulating DNA becomes a possibility to rescue some of these patients, because alternatively, all you have is a rebiopsy.
Thank you.
Okay, I think it's time to close. Besides, we can cover all of the issues on this topic. So it will be a pleasure to be back with us at the future meeting, Professor De Castro, and discuss all the other issues on this topic.
Yeah, I'll be looking forward to, hopefully the next one is face-to-face very soon.
Nice
Very
to
much.
hear that.
Yeah. Thank you very much for inviting me. Thank you very much.
Thank you very much. It was really a great pleasure to be with us today and share your experience.
Thank you very much. Bye-bye.
Bye. I would like to thank you all for attending. Thank you very much and hope you enjoy our today pathology meeting. Bye.
Bye.